Hi, it's Lisa Salberg. I'm here on the floor of the American College of Cardiology Conference in San Francisco, California. It's Monday and the convention is just about wrapping up, but I wanted to give you a couple of highlights from this particular meeting as they pertain to hypertrophic cardiomyopathy. Number one, really exciting article that was published earlier this month in Circulation from Dr. Marins regarding the age of diagnosis. For those of you who are diagnosed with HCM over the age of 60, prognosis looks good and your likelihood of sudden cardiac arrest or heart failure death is very low. Additionally, we talked about really narrowing down the role of alcohol septal ablation to its proper place as a very limited option for those with the appropriate anatomy. Now, I know there has been some contention out there, one over the other, but it turns out that outcomes are much better for myectomy. And in fact, even in Europe, where surgery had been abandoned, basically, they're now revamping their surgical programs because it's very clear that they are not equal procedures. They are meant for different populations. In other interesting news on myectomy, there was an interesting poster from the group at Tufts regarding how many patients with hypertrophic cardiomyopathy undergoing myectomy actually needed way more than a traditional myectomy. That they needed cords shortened, they needed their mitral valve worked on, and it really solidifies our belief that centers of excellence are critical to the treatment and management of patients with HCM because it's not just a straightforward myectomy. So that was an interesting poster. Hopefully they're going to publish that data soon. Other interesting data, apical HCM, the group from Mayo did some great work on great MRI images of the anatomy of the apical hypertroph and looking at genetics in apical HCM, and it's much more difficult to find genetic markers in those with hypertrophic cardiomyopathy, so it also lets us know where we can have our highest yields in genetic testing based on anatomical presentation of HCM. What else did I learn in the last couple of days? The role of ICDs still being refined. Delayed enhancement on MRI being used as a risk factor is something that I think we might see in the future. It's not quite ready for prime time, but if you have over 25% of your myocardium affected by delayed enhancement, which is scar and fibrosis, it's probably a risk factor, but we're still working on getting enough data to prove that's really an independent risk factor. So if you have one of the weaker risk factors and you're on the fence and you have a lot of delayed enhancement, it probably is enough to push you to an ICD. What else can I tell you? That's about it for now from the American College of Cardiology in San Francisco. And we're taking the red eye back to the East Coast tonight for my meeting in New York City on Wednesday. Hopefully some of you will join us at Columbia for the presentation on restrictive and hypertrophic cardiomyopathy. So that's about it from California. Stay well, stay healthy, and stay informed. Bye-bye.